from APDA, Virginia.
Thank you, Bill. Welcome, everyone. My name is Donna Magoon, and I am the chapter coordinator at APDA's Virginia chapter. Thank you so much for being with us today. I'm pleased to welcome you to the second of our three-part educational webinar series. These webinars are designed for people with Parkinson's disease, as well as their care partners, family members, and healthcare providers. We're very grateful to Dr. Alex Dalrymple today for volunteering his time to present this topic. What's new? Recently approved medications for treatment of acute off periods in Parkinson's disease. After some brief announcement, Dr. Dalrymple will present his topic. After that, there'll be a Q&A session where you'll be able to ask the questions about your questions about today's presentation. Just to give you a little background in case you don't know APDA, the American Parkinson Disease Association Virginia chapter for short is part of the largest grassroots network dedicated to fighting Parkinson's disease and to helping more than the 1 million people with Parkinson's disease who live life to the fullest in the US. The APDA Virginia chapter offers a variety of services to our constituents around the Commonwealth. You can visit our website to explore all that we have to offer. The website also hosts a variety of publications, webinars, articles, research updates that can help you understand Parkinson's disease. If you're participating from another state, know that we have chapters and locations all around the United States, and you can find that contact information on our website as well. APDA Virginia is also available through our helpline, our email, and social media. One noteworthy achievement I want to highlight while we're on this slide is in the lower right. APD Virginia's support in the amount of approximately $3.4 million in research for Parkinson's disease within the Commonwealth. So we are very, very proud of that achievement. You can ask questions anytime during the presentation by typing your question into the Q&A section at the bottom of your screen in Zoom. The Q&A session will follow Dr. Dalrymple's presentation. Special thanks go out to our sponsors, Amneal Pharmaceuticals, the manufacturers of Rytary, and Kyowa Kirin, manufacturers of Nourians, for generously supporting this program and to acknowledge their appreciation for the critical need to provide programs like this one. You can visit their websites for more information about their products and services. Today, we are pleased to have with us Dina Weddle from Kyowa Kirin, who will introduce Dr. Dalrymple. Welcome, Dina. I believe Dina is with us.
Yes, I am.
Hello.
Dude, sorry about that. Gotta love technical difficulties. Excuse me. Thank you, Donna. It is my pleasure to introduce Dr. Alex Dalrymple, who is board certified in neurology and is a fellowship trained movement disorder specialist. He also, hold on, I had his bio, that's okay. His focus is on improving quality of life for his patients, educating the next generation of physicians, and participating in meaningful research. He joined the faculty at UVA in January 2021, where in addition to seeing patients, he also serves as an associated director of the Adult Neurology Residency Program and is co-director of the Huntington's Disease Clinic. We are so thankful to have Dr. Dalrymple here with us today. So without further ado, Dr. Dalrymple, welcome, and thanks so much for joining us.
There we go. I think I'm unmuted now. Thank you for that, Dina. That was very kind introduction. And huge thanks to the APDA, to Donna, to everyone involved. Thank you for inviting me here. Really happy to give this presentation today. So today, I'm going to be talking about abortive therapies for off periods in advanced Parkinson's disease. I have no disclosures. So I'm going to get started with a patient scenario that is actually fairly common in my practice. So let's say a patient comes in for their regularly scheduled Parkinson's disease follow-up appointment. Parkinson's was diagnosed about 12 years ago, and the patient's on a few different medicines. They're on carbidopa, levodopa, the instant release tablets. They also take some controlled release tablets. They're on amantadine, and they're on entacapone. The main complaint is that the levodopa doses just don't seem to last long enough. So not only is there early wearing off, or the medication seems to get out of the patient's system before the next dose is due, but sometimes that wearing off effect is sudden and can be unpredictable. At times, there are even complete dose failures where the patient feels like they take a dose of medicine and it just never seems to kick in. It never seems to get into their system. And they're really kind of frustrated about this. They're like, "Doc, what can I do about this?" So before I go further, I want to define some terms that I'm going to be using for the rest of this talk. And this talk, by the way, is not going to be an hour long. It's probably going to be closer to 25 or 30 minutes because I wanted to make sure to leave some time for questions for everybody. So like Donna said, please make sure to use that Q&A function, and we'll try to get to a lot of the questions at the end. So the first thing that I want to try to define is on versus off. We use this all the time as Parkinson's disease physicians in communicating with one another, communicating with patients. But it's something that may not be clearly defined for a lot of you guys. So on periods, on is the period of time where the medications, levodopa, other medicines for Parkinson's, are in the patient's system and are working well to help control the motor symptoms of Parkinson's disease. Contrast that with off times. Off is the period of time where the medications, levodopa, whatever other medicines the patient might be on, are not controlling the motor symptoms of Parkinson's disease. Off times can occur predictably. So say a patient takes their medication every 5 hours. They know that come about 4.5 hours after their last dose, they're going to start wearing off and they're going to have a predictable off time right before their next dose is due. But off times can also occur unpredictably, without warning, and can sometimes even occur suddenly. So the patient can be functioning just fine, and then all of a sudden the medicine sort of wears out of their system and they have a much harder time moving. The other term that I want to define is fluctuations, motor fluctuations to be precise. So when I say fluctuations, what I mean is alternating between on periods and off periods, on periods and off periods throughout the day. The way that I think of it is kind of like a roller coaster. So motor fluctuations are a fairly common thing that we see in Parkinson's disease, even from early on. That patient scenario that I presented earlier is, I see multiple patients a week who have issues like this. We have a lot of treatment options for motor fluctuations in general. So we can take the instant release carbidopa, levodopa, and we can change it to controlled release. We can change it to extended release capsules. We can add medications like entacapone or opicapone, both of which are supposed to make the levodopa last longer in the patient's system. We can add medications like rasagiline or selegiline, both of which are also supposed to make it last a little bit longer. We can even do brain surgery, deep brain stimulation. One of the major indications for that is to try to reduce these motor fluctuations. All those are great, but what do we do when the fluctuations are happening in the moment? How do we treat the patient at the moment when they are suddenly off? That's the main focus of what I'm going to be talking about today. There are 3 new medicines that have been approved just over the past few years to combat this problem, how to treat those acute off periods in the moment when they happen. So these three newish medications for acute off periods are inhaled levodopa, subcutaneous apomorphine, and sublingual apomorphine. So I'll now go through each of these in order and fairly in depth. We'll start with inhaled levodopa. So inhaled levodopa, as you might expect, it's a powder form of levodopa that's administered, obviously, through an inhaler into the lungs. By inhaling it, it allows the levodopa to bypass what we call first-pass metabolism. So whenever you take oral medication, you take a pill, it goes into your stomach dissolves it, and then it goes into your intestines where it's absorbed into the bloodstream. But everything absorbed into the bloodstream from the intestines then is shunted to the liver. The liver then sees whatever that is, that medication, and changes it or adapts it or lets it pass through, but it always has a checkpoint at the liver before it gets into the bloodstream and goes to the rest of the body. By inhaling levodopa, the levodopa gets into the lungs and then goes directly into the bloodstream and is able to bypass the liver, right? So it doesn't make that other stop at the liver first. What this means is that it's quicker, right? The levodopa can get into the bloodstream and into the brain, most importantly, faster than if it's swallowed. It also leads to better what we call bioavailability. In other words, we can use less levodopa to get a similar effect. So the inhaled levodopa actually comes in capsules. I'll show you a picture, I think, in the next slide. Each capsule has 42 milligrams of levodopa, and patients are instructed to inhale 2 capsules at a time up to about 5 times a day. So this is a picture of what the inhaler looks like. Whenever it's closed, it's a blue oval. So you can see the blue handle and blue cap there. They fit together, it forms a closed oval. You take the cap off, you can see the white mouthpiece. You can actually pop that mouthpiece off and you see the capsule chamber here. That's where the 2 capsules are loaded in. The mouthpiece is clicked back on, and then the patient inhales the powder. Inhaled levodopa is FDA approved for the intermittent treatment of off periods in patients with Parkinson's disease who are currently treated with carbidopa levodopa. Now, as with any medication, there are some contraindications, some things to watch out for. With this one, the big one is patients cannot have used non-selective monoamine oxidase inhibitors within the past 2 weeks. Now, non-selective monoamine oxidase inhibitors are still used somewhat, but have kind of fallen out of favor over the past years to decades even. They're relatively old medicines. If we're going to use monoamine oxidase inhibitors now, at least in the Parkinson's world, almost always they're going to be selective monoamine oxidase type B inhibitors, medications like selegiline and rasagiline. And those medicines are okay to use with inhaled levodopa. Okay, so don't worry, if you're on one of those, the inhaled levodopa is okay still. Side effects of inhaled levodopa: you're inhaling a dry powder. Most common adverse reactions are cough, nausea, cough, upper respiratory infection, cough, discolored sputum, and I'm not sure if I mentioned cough yet. Other things to think about, because you're inhaling a dry powder, patients with underlying lung diseases, it's probably not recommended that they try this. So asthma, significant asthma, COPD, restrictive lung disease, things like that, this is probably not the best choice. Inhaled levodopa also has other side effects that are similar to oral levodopa. It can cause or worsen dyskinesias. It can exacerbate hallucinations. It can make psychosis a little bit worse. And then abrupt withdrawal can actually lead to what we call a hyperpyrexia syndrome. So let's get down to, in real life, okay, weighing the pros and cons, how useful is this medicine? In my experience, and in the experience of a lot of my colleagues here at University of Virginia, cough is really often a limiting factor. Inhaling a dry powder is not the most comfortable thing to do. Another limiting issue is, I don't know if you remember the slide that showed what the inhaler actually looks like. But essentially, in order to make it work, the patient has to take the blue cap off, take the white mouthpiece off, fish out 2 levodopa capsules, get them into their correct little capsule slots, put the mouthpiece back on, and then inhale this powder. By definition, the patient is asked to do this when they're off medication. Now, I don't know how many of you have significant off periods, but a lot of my patients say that, fine motor tasks are particularly difficult when they're off. So manipulating this when you're off medication can be pretty tough. Also, the world we live in, right? It's a new medicine. It's fairly expensive. It can be difficult to get insurance approval for this. So here's an example of when it might be useful. We had a 60-year-old male who's diagnosed with Parkinson's disease about 17 years ago, age 43, so fairly young when he was diagnosed. He actually had a deep brain stimulator placed in 2014 on both sides of his brain, in the GPI, for those of you who are familiar with that. His main motor symptoms are bradykinesia, or slow movements. He has significant fluctuations. Importantly, he has those sudden and unpredictable off times that are so frustrating to deal with. And then he has some freezing of gait too. As far as non-motor symptoms, he has what we call RBD, stands for REM sleep behavior disorder, or dream enactment behaviors, acting out of his dreams, punching, kicking, yelling out while he's sleeping, things like that. He also has some mild cognitive changes, but doesn't have many hallucinations, delusions, or impulse control issues. He's on quite a few different medicines, including instant release carbidopa, levodopa. He takes about 2.5 pills at a time, 4 times a day. He has a controlled release tablet, the big one, the 5200 pill that he takes nightly. He's on ropinirole 4 times a day. He's also on some sertraline for his mood, and he takes melatonin at night to help him sleep. In the past, he's been on amantadine. He's been on the carbidopa, levodopa extended release capsules. So he's tried a lot of different things, and he has the deep brain stimulator. But he continues to have those significant fluctuations with sudden and unpredictable off times. We prescribed inhaled levodopa, 84 milligrams, right? So 2 42 milligram capsules. We told him to use it up to twice a day as needed. And he honestly found it helpful sometimes. Especially the first few times he used it, he complained of a cough and he complained of some difficulty manipulating the cartridge. Both of those he felt like got better with repeated use. So I think he sort of learned how to manipulate the cartridge a little bit better. And I think he learned how to inhale it without necessarily making himself go into a coughing fit. So it still works for him. And he continues to use it, the inhaled levodopa, probably about 2 to 3 times a week as sort of his rescue medicine for sudden off periods. I talked to him, he actually literally puts the inhaler in his back pocket so that he has that whenever he goes out somewhere in case he has one of those sudden, unpredictable off times. He can pull out the inhaler, get the cartridges loaded in, inhale, and then within 10 minutes or so, he feels like he can move easier again. So that was inhaled levodopa. Next up, we're going to talk about subcutaneous apomorphine. First, a little bit about apomorphine itself. I know the name is probably throwing a lot of people off. Despite its name, it is not a morphine derivative, right? So it is not related to morphine. It is not an opiate, does not bind to opioid receptors. What it is, it's a dopamine agonist. So in other words, it binds to dopamine receptors and activates those, okay? So it's not an opiate. It also binds at a few other receptors and can inhibit their activity, but for the purposes of our talk today, think of it like a dopamine analog. Okay, so subcutaneous apomorphine are injections of this medication under the skin, and they are FDA approved for acute intermittent treatment of off episodes in advanced Parkinson's disease. Now with subcutaneous apomorphine, big contraindication, you can't use it at the same time as using certain types of nausea medicines. Ondansetron is an example. The reason is use of subcutaneous apomorphine with these agents has actually led to pretty profound drops in blood pressure, so much so that patients have lost consciousness and passed out. Also, obviously, any patient who has a hypersensitivity or allergy to apomorphine probably shouldn't prescribe this medicine to them. The major side effects of subcutaneous apomorphine are drowsiness, dyskinesias, nausea and vomiting, orthostasis, which is drops in blood pressure when standing up and lightheadedness, rhinorrhea, which is runny nose, hallucinations, and extremity edema or swelling. So here's a picture of what the subcutaneous apomorphine injector pen looks like. You can see there's a needle. It's a very fine, about 29 gauge needle, similar to what patients with diabetes use to inject insulin into themselves. There's a rotating dial that you can select which dose you need. And then inside the body of the pen, there's a multi-dose cartridge. Everything comes in this handy dandy little carrying case here. So essentially the patient just selects what dose they need. Usually they'll probably keep it on the same dose setting. And they can whip out this pen, inject themselves, and then go about their day. So other major considerations with subcutaneous apomorphine. Apomorphine has been inadvertently administered intravenously or directly into the bloodstream rather than under the skin before. And when that happens, that in certain cases can lead to clot formation and even things like pulmonary embolism, right? So the clots can form and can travel elsewhere if it's injected directly into the bloodstream. So prescribing this and teaching a patient how to use the subcutaneous injector is a huge deal, because we have to make sure that they're injecting it properly and they're not risking injecting it directly into the bloodstream. This subcutaneous apomorphine can also lead to certain types of heart rhythm abnormalities, specifically a prolonged QTC interval. So frequently we will check an electrocardiogram, an EKG, before prescribing this medicine and make sure that the QTC interval isn't close to being prolonged as is. Also, subcutaneous apomorphine can lead to worsened impulse control. Essentially, patients can have trouble, like it says, controlling their impulses, can have trouble making decisions that they probably shouldn't be making. So realistically, subcutaneous apomorphine is a relatively new medication, fairly expensive. It can be difficult to prescribe and get covered. As I mentioned before, it does require some significant teaching, especially if a patient, doesn't have diabetes, doesn't have experience with subcutaneous injections in themselves. We have to, either a physician or a nurse or somebody has to teach the patient, any family members who may be involved, exactly how to select the dose, exactly how to, clean the skin with alcohol, how to do the injection itself. And then because nausea and vomiting are a potential side effect of this, it's actually recommended to use an anti-nausea medicine with subcutaneous apomorphine. But if you remember, certain nausea medicines we can't use with it. So it's sort of like we're between a rock and a hard place, where it can lead to nausea, but a lot of treatments for nausea make things even worse. So we have to be pretty selective in what we can use for the nausea. So here's a patient example where subcutaneous apomorphine was actually the perfect thing. This is a 63-year-old female. She was diagnosed with Parkinson's disease about a decade ago. After she developed a soft voice and some right-sided bradykinesia or slowness. She has significant motor fluctuations. She has sudden and unpredictable off times. We tried transitioning her to the carbidopa levodopa extended release capsules back in 2019, and that helped for maybe a year or so, and then her fluctuations started coming out again, and by late last year they were sudden and unpredictable, and pretty bad. Her off time specifically actually manifests as a painful foot dystonia. When I say dystonia, what I mean is abnormal sustained contractions of muscles. For her specifically, her foot wants to curl down, curl in, and then her toes curl. And if you can imagine kind of trying to do that with your foot and leaving it there for a while, it gets pretty cramped. It gets extremely painful to the point where whenever she has one of these sudden off times, her foot all of a sudden cramps up like that, and she essentially can't walk. So this is a pretty debilitating symptom for her. We had talked to her about deep brain stimulation a few times. She's adamantly against it because she had a distant family member, a second cousin or something, who had a different kind of brain surgery and had a complication. And so she absolutely does not want deep brain stimulation, which is fine. Ultimately, it is still brain surgery, right? I don't want to force a patient to do anything. She has tried taking her regular instant release levodopa, but even when she crushes it or chews it, it can take 45 minutes, 50 minutes, up to an hour to alleviate that painful foot dystonia for So we decided we'd try subcutaneous apomorphine. She is a quick learner. She learned how to do the injections pretty fast. She's a pro at it now. And luckily, she can do that. She can inject herself, and it reaches its peak effect within about 10 or 15 minutes. So that's still longer than ideal for having a debilitating, immobilizing, painful foot dystonia. But we essentially reduced that time that she's in that pretty significantly. From 45 minutes to an hour, all the way down to 10 or 15 minutes. Last up, we have sublingual apomorphine. So sublingual apomorphine is also apomorphine. It's the same active medication. It's just a different route of administration. It is FDA approved for acute intermittent treatment of OFF episodes in Parkinson's disease. Just like subcutaneous apomorphine, you cannot use it with certain types of nausea medications. Ondansetron is probably the most common of those. Because of the profound drops in blood pressure that can lead to loss of consciousness when you use them together. And again, I have to say this, anyone who's hypersensitive or allergic to apomorphine, obviously we shouldn't use this medicine in them. The main side effects of sublingual apomorphine: nausea and vomiting, somnolence, oropharyngeal or mouth, tongue, throat pain, and paresthesias. Paresthesias means tingling. Mouth and throat edema or swelling, and dizziness. So this is what the sublingual apomorphine looks like. You can see it's a small film like this, kind of like those old Listerine breath strips. Although I gotta admit, I've tried one. It does not taste like the Listerine breath strips. Doesn't taste awful, don't get me wrong. But it does not necessarily leave your mouth feeling minty fresh. They each come individually wrapped. So the patient, all they need to do is undo the wrapper, take the strip, place it under their tongue, and then within a few minutes, the medicine has dissolved under the tongue. Just like subcutaneous apomorphine, sublingual apomorphine can lead to certain types of heart rhythm abnormalities, specifically a prolonged QTC interval, and it can worsen impulse control. Now, as far as realistic utility, one of the big things with sublingual apomorphine is it requires a supervised dose titration visit. These films, the individual sublingual films, they come in doses ranging from 10 milligrams to 30 milligrams. And they're every in 5 milligram intervals. So 10, 15, 20, 25, 30 milligrams. There's no great way to tell which patient will need which dose. So when this medicine was being studied and shortly after it was approved, what we had to do was actually bring patients into the office, have their medicines wear off, wait until they're off medicine, give them the lowest dose, see what happens. Then wait until they're off again, give them the next highest dose and see what happens, right? And as you can imagine, that took up a lot of doctor, nursing, patient time. Now, luckily, we can do this with the supervision of a clinical educator that's actually provided by the pharmaceutical company. What makes it even better is the clinical educator can go to the patient's home in the before times, pre-COVID, and now they can even do this dose titration visit via telemedicine. So it's way more convenient for everybody involved to do this dose titration visit. The other utility issue with sublingual apomorphine is similar to the subcutaneous apomorphine. It is recommended that we use it with an anti-nausea medicine because nausea is such a common side effect. But remember, we're limited in the number of nausea medicines we can choose because we can't use it with certain nausea medicines. That said, some post-marketing studies of sublingual apomorphine have shown that for most patients, even though they do experience some nausea, most of them, it's not that big of a deal. It's fine even if they don't take a nausea medicine for it. So another patient example. For sublingual apomorphine, we had a 59-year-old male who was diagnosed with Parkinson's disease in 2009. So also fairly young when he was diagnosed. He was diagnosed after he had onset of left arm and hand tremor, and he actually had a bilateral DBS implanted in 2013 to his GPI. Unfortunately, despite medications in the DBS, he still has sudden and unpredictable off times. His off times, unlike the previous patient who we were mainly dealing with a foot dystonia that was very painful and cramping. This patient's oftentimes manifests with severe akinesia. So bradykinesia means slow movement. Akinesia means lack of movement. It's essentially bradykinesia taken to its extreme. He gets locked up to the point where he literally physically can't move. His oftentimes also have severe dysphagia, which is trouble swallowing. So if you can imagine, he will have a sudden, unpredictable off time, essentially be frozen in place and can't swallow. So he can't take his normal medicines to relieve that off time, to get him back on again. Because of that, this is sort of snowballed in the past to the point where he's actually been hospitalized more than once due to kidney damage from muscle breakdown from his inability to move. So we knew we had to do something, right? He was on a lot of different medicines. He was on multiple forms of carbidopa, levodopa. He was on amantadine. He was on reticotine patches. He, like I said, already had the deep brain stimulator. We had adjusted that here and there and everywhere, but he was still having these bad, sudden, unpredictable off times. Because his off time, one of the biggest, most debilitating symptoms was inability to swallow. We thought, you know what? What if we give him the sublingual apomorphine? You don't have to swallow that. All you have to do is get the film inside the patient's mouth, give it a few minutes, let it dissolve, and the medicine should hit. So we prescribed it. He was titrated to the 20 milligram dose, which a lot of patients are winding up right at that 20 milligram, the sweet spot right in the middle. And he has found it to be mostly helpful. He admits it's not perfect. It doesn't completely relieve the off symptoms, but it relieves them enough that he can then take his other medicines. He can swallow those well enough, and then we can sort of relieve that snowballing effect. So I'd be remiss if I didn't mention one other option for the acute treatment of off periods in Parkinson's disease. And honestly, one of my favorite ways, and the one that I usually try first, is I just ask the patient to chew up their regular instant release carbidopa levodopa. When you swallow a pill, the whole pill has to get dissolved down into the powder before it can be absorbed. When you chew it up, you're already breaking it into a powder. It gets absorbed a lot more quickly. Now, I'm sure some of you have probably chewed up carbidopa levodopa. Some of you who haven't chewed it are probably looking at me right now and thinking, you're asking me to chew a medicine? I've never tried this myself, but I promise I've heard from a lot of people, it just tastes chalky. It doesn't taste awful. It's chalky. It's not the most pleasant thing, but it's not like horribly bitter medicine taste. So frequently, whenever patients come in with acute off periods, like I've described, this will be my first step, as I say, well, just carry a few extra carbidopa levodopas with you and either break one in half or take a whole one and chew it up and see what happens. And frequently it will reach its effect within 15 minutes or so. All right, so I told you this talk was going to be relatively short. I just have one quick review slide going over all three medicines that I mentioned earlier. So inhaled levodopa, it's pretty fast acting. It is fairly convenient, but it can be difficult to manipulate that inhaler cartridge and frequently leads to a cough. Subcutaneous apomorphine is also pretty fast acting. A little bit less convenient because it requires an injection. It's probably not the most comfortable thing. But once you get used to the injections, it's still fairly convenient. And then it can lead to nausea as well. Remember, like I said, we can't use certain anti-nausea medicines, so that can make that extra difficult. Then sublingual apomorphine is also fast acting and convenient. It requires that titration visit that now is a lot easier than it used to be. And it can also lead to nausea and then oral tingling, which some people don't mind and some people find to be fairly uncomfortable. So thank you for sticking around. I'm sorry, I know there were a lot of words on the slides, not too many pictures or things, but I hope a lot of that made sense, and happy to take any questions you have. I'll go through the Q&A.
Okay, this is just to remind everybody who's attending that you can type a question into the Q&A section at the bottom of your Zoom screen, and we are monitoring those questions. Thank you.
Yeah, thanks, Donna. So there are a handful of questions in the Q&A. I'll get to those in order. So the first one, I apologize, anonymous attendee. I meant to actually say this on the slide about the inhaled levodopa. Can the inhaler be preloaded? You're not the first person to have thought of that. That's a great idea. Unfortunately, they say that we cannot preload the inhalers. So the capsules, once the inhaler is loaded, the capsules are broken and the powder is sort of exposed. And so they recommend against preloading those inhalers. So have I done anything with high dose thiamine? I personally have not in the treatment of Parkinson's disease. I do know of a colleague of mine who's actually interested in a different B vitamin, niacin, but I don't think it's more of a theoretical interest. I don't think we've actively done anything with it yet. Another question is, how about dissolving in some water as an alternative to chewing the carbidopa, levodopa instant release? I think that's a great idea too. I think the reason I largely suggest chewing is because that way you don't have to go get a glass of water. You know, and I'm not sure that dissolving in water would necessarily make it taste any better. You know, one of the most common times that I ask patients to chew up carbidopa, levodopa is overnight, right? They last take their medicine at, you know, bedtime or sometime before bedtime, and then they won't take any again till the morning when they wake up. If they wake up at 2 a.m. and have to use the bathroom, but all their medicine is worn off, they may have trouble getting to the bathroom safely. They may have trouble once they get back from the bathroom, finding a comfortable position in bed and falling back asleep. For those patients, I say, you know, keep a half a pill or a pill at your bedside table and just chew it up if that's the case. But dissolving in water, I think would work just as well. And then the second part of that question was, I guess you can't chew or dissolve the extended release or the controlled release capsules. And that's exactly right. That chewing them or dissolving them would kind of defeat their instant and controlled release purpose. Had another question about any rhabdomyolysis side effects. I'm not sure which of the medications you're referring to, but I don't think so. So rhabdomyolysis is muscle breakdown that then leads to kidney damage. And that's what I was referring to in the last patient. But that was an effect of his off periods. Essentially, he would get so frozen, rigid, unable to move, and unable to take medicines that could get him back on that he would actually start breaking down his muscles, and that will lead to kidney damage. Another question about the heart rhythm and impulse control side effects of these medicines. Are they permanent or only while using the medication? In general, most of those side effects are only while using the medication. The impulse control especially should go away fairly quickly after discontinuing a medicine that has that as a side effect. The heart rhythm abnormalities, it may take a little bit longer, but even that should go away. It'd be one of those things where we would check an EKG before prescribing the medicine, and then check one after the patient has been on the medicine for some time. And if we see a new heart rhythm abnormality, we would probably just have to stop the medicine. We would check another EKG after that and make sure that it's okay, you know, that it's gotten back to normal. So they should only be there while using, but they could take a little while to get better after stopping the medicine. And another good question. Do you have to have a diagnosis of Parkinson's disease for a certain time before trying these medicines? Depends on the medicine that you're talking about. So not particularly. In fact, for the sublingual apomorphine, I think they were fairly specific in getting FDA approval for acute off periods in Parkinson's disease compared to subcutaneous apomorphine, where the FDA approval says acute off periods in advanced Parkinson's disease. So ultimately, I think if you have a diagnosis of Parkinson's disease and have sudden acute off periods that aren't handled through, you know, some of the other means like chewing up carbidopa, levodopa, or switching to a controlled release form or things like that, I think these medications would be useful regardless of how long you've had the PD diagnosis. Another question, why not just chew the carbidopa levodopa anytime? I'm assuming that means whenever you take your regular doses, why not chew it? And really my only reason for that is, or the only reason not to do that is because it probably doesn't taste great. You know, if you're not in any rush for the medicine to get inside your system, then I don't know that you necessarily need to chew it. Also, by having absorbed a little bit faster, it does probably come out of the system a little bit faster. So for kind of standard day-to-day utility, swallowing the regular pills is probably best, but keeping a few in your back pocket to chew in case the medicine wears off suddenly is usually what I recommend. Got another question. What about dyskinesias? What can be done if amantadine isn't working? That's a great question. So for those of you who don't know, dyskinesias are uncontrollable kind of writhing movements that happen, and they're often a side effect of levodopa. They can be bothersome or non-bothersome. I have a lot of patients who have, you know, mild dyskinesias that they don't even notice, but they, in their severe form, they can be fairly bothersome. Amantadine is a medicine that we can use oftentimes to try and control those, but amantadine has its own issues and isn't perfect. So there are lots of other things we can do to help with dyskinesias. One, maybe the best thing is try to somehow rearrange the levodopa dosing, whether that means, you know, lowering the amount that's taken at each dose and maybe taking doses closer together, or switching to a more controlled release form or the extended release capsules. Those things can frequently help smooth out the dyskinesias. And then also ultimately things like deep brain stimulation are very helpful in reducing dyskinesias. Just going through this Q&A in order here. The next one up is a comment saying you can buy pill crushers and use that instead of chewing the pills. You can actually put some water in the crusher with the powder and then you can drink it. And that's a great idea. Yeah, that's perfect. If you don't want to chew up the pills, you can just crush them and then take the powder, put the water in there, and then drink that slurry. Next question is a very good one. Do you have any knowledge of drugs that inhibit or reverse aggregation of alpha-synuclein? So alpha-synuclein is a marker of, well, abnormal alpha-synuclein deposition is a marker of Parkinson's disease and a few other related diseases. It's essentially an abnormal protein aggregate that that we can see under a microscope in the brains of folks who have had Parkinson's disease. The leading theory is that when alpha-synuclein aggregates, it is one of the things that leads to the degeneration, leads to the damage in the brains of folks who have Parkinson's disease. Therefore, drugs that inhibit or reverse aggregation of alpha-synuclein should theoretically be able to limit or reverse the damage that's been done. There are a few trials. One that I know of in particular was just a phase 1 trial of a monoclonal antibody that was supposed to prevent alpha-synuclein from aggregating. Because it was a phase 1 trial, I have to admit that I haven't been keeping up with it that much. I know that it exists, but I don't know if it's finished yet or if it has results. Largely because the phase 1 means that there's still a long way to go before it would be clinically applicable. Other than that, you know, I think the topic of alpha-synuclein could probably be its own multiple-hour lecture. And I don't want to start any controversies here, but I know that there are some people who aren't even sure if alpha-synuclein is the right target, if that makes sense. But to answer the question, do I have any knowledge of drugs that inhibit or reverse aggregation of alpha-synuclein? There is at least one trial I know that's ongoing. It is still very early phase, and even if it winds up being successful, I think we still have years and years before it would be approved. Then I think we had a clarification on the preloading question. I think this is about the levodopa inhaler. They meant that the patient with Parkinson's disease could preload the inhaler before sticking it in their back pocket to take out. And even that, the pharmaceutical company basically says they strongly advise against putting those capsules into the inhaler before you're going to use it. So the patient could put the inhaler in their back pocket and a few of the capsules in the back pocket. But you're not supposed to put the capsules into the inhaler until you're ready to use it. Another good question here. I have inside tremors. What do you suggest for these? So this is something that I hear pretty frequently. Inside or internal tremors, where it feels there's clearly shaking tremor going on inside somewhere, but patients are trying to describe this to me. I can't see them because they're going on inside. Most frequently, what I do when I encounter patients with that is I really try and drill down, when are they happening? Especially when are they happening in relation to when you take your medicines or when other things are happening, right? Does stress bring them on? Do you tend to get these internal tremors more in the half hour before your next medicine dose is due? Do you tend to get them more after you've had a big meal? Any sort of clue like that then helps me work with the patient to adjust their medicines in a way that hopefully can relieve the internal tremors. I don't know that I have a blanket suggestion on what to do aside from trying to work with your doctor to figure out what the triggers might be and how you might be able to adjust things to make it better. Okay, another question. Are there any biomarkers of off periods? So that's a good question. For those of you who don't know, biomarkers are basically measurables, things that we could measure that show presence of or progression of a disease. As an example, in things like prostate cancer, right? There's the prostate surface antigen, or PSA, which has sort of gone back and forth in primary care circles about whether it's useful or not, but it's a number. You can get blood work done, you can see this number, and theoretically a higher number means more progression, a lower number means things are looking better. This question, I believe, was asking about, are there any biomarkers of off periods in Parkinson's disease? And there aren't that I know of. There are not that I know of. In fact, there aren't biomarkers in general is a very hot area of research in Parkinson's disease. Right now, we don't really have any great biomarkers. What we use to determine progression of disease is symptom progression, right? So we know that the disease is continuing as the symptoms get worse over time. This makes it difficult because a lot of the medicines we have, all the medicines we have for Parkinson's, help to relieve the symptoms. So for a long time, there was some confusion as to whether a lot of the medicines were relieving the symptoms or were actually slowing down progression of the disease. Now we're fairly sure that just about all the medicines, unfortunately, only relieve the symptoms. They don't actually slow down the progression of the disease. So finding another biomarker that's independent of the patient's symptoms at the time is, there's a lot of research dollars and a lot of research time going into that. To my knowledge, we don't have that yet. Another question, could I give a price range if these medicines aren't covered? Unfortunately, I don't think I can off the top of my head. I do know that frequently the pharmaceutical companies that make these will try to work with you. and we'll have programs, you know, where I don't want to say the wrong thing, right? But the bottom line is I can't give you an actual price range. I don't know. But if one of these medicines is something you're interested in and insurance is not covering it, I would try to look onto the medication's website or contact the pharmaceutical company and see what they could do. Another question is, could the extended release amantadine cause balance issues such as retropulsion? I'm not sure that it directly causes balance issues. I know that retropulsion balance issues are something that we see in Parkinson's disease itself. To be honest, I don't prescribe much of the extended release amantadine, largely because I've had trouble getting it covered by insurance as well. Frequent theme of mine. Here's a good question that I think is worth clarifying. When you chew carbidopa levodopa, is it the extended release or the immediate release? This is the immediate release that I'm talking about. So frequently it's the yellow pills. And then I think I got my sign for maybe one more question. What do you do if the carbidopa levodopa doses just stop working, even though the dosage has been increased? That can be tough. So I think you'll need to probably talk with your neurologist about that, because my questions would be, when you say stopped working, is it just less effective than it used to be? You know, do we need to increase the dose? Is it not working for as long as it used to? Is it that every now and then you'll take a dose and it won't seem like it's working at all? Or is it that actually, no matter how much you take, no matter how often you take it, it doesn't seem to be doing anything? And those are all questions that I'd suggest you clarify with your neurologist, because I think each of those would have a different answer. I think that's all. I'm sorry if I didn't get to everybody's questions. I'm happy to, you know, maybe take more. I don't know, Donna, you know, if you get other questions after this, feel free to send them my way, and I'm happy to answer them over email.
Thank you, Dr. Dalrymple. That is exactly what we will do. We will be monitoring the questions that come into us, and we will send them your way. Thank you so much for a wonderful, informative presentation today.
Thank you so much for having me. This is fantastic.
It's been our pleasure. It's been our pleasure. So I want to remind the audience that we have the APDA symptom tracker. And I think we have a slide coming up that'll show you what that looks like. It exists to help you and your loved ones track their PD symptoms. The symptom tracker is available in both English and Spanish and can be downloaded from the App Store or Google Play. On behalf of the APDA Virginia chapter, I want to thank you, Dr. Dalrymple, the participants, and of course our sponsors, Amneal Pharmaceuticals and Kiowa Kieran, for supporting our program. If you know someone who missed today's program, if you joined later, if you would just like to watch it again, a recording of this presentation will be posted to our website in the next week. We encourage you to visit us at apdaparkinson.org/VA for more information about APDA and Parkinson's disease. Thank you all for participating today. Have a great weekend. For those of you in the snow belt, stay safe, and we look forward to seeing you in February. Thanks so much to everyone.